Good afternoon. This is the Retina lecture presented by me, Dr. Suzanne, for our fifth class student in Al-Kindy College of Medicine. The objective of the lecture to study the retinal anatomy, some point regard retinal physiology, and certain common retinal diseases. As you know, the retina is the nervous coat or the internal layer of the eyeball. What is the function of this layer? In this layer, the optical image is formed by the eye optical system. And here the photochemical transduction reaction occur. So the nerve impulses are created and transmitted along the visual pathway to the brain. In the brain, there is high cortical processing for the image. Let me explain to you this diagram. This diagram showing the arrangement of the nerve cell within the retina. In the retina, there is 10 layers. The outer retinal pigmented layer, or called retinal pigmented epithelium, and the remaining 9 layers is the neurosensory retina. Let us start with each one alone. From the outer is the retinal pigmented epithelium. As you see, there is a single layer. This is a monolayer. The cell here is tall and hexagonal in shape. The base of the cell, there is tight junction between the cell and the other apices. At the apices, there is microvilli. As you see in the picture, the base of the retinal pigmented epithelium, there is microvilli that surround the outer segment of the photoreceptor. This arrangement is very important. The importance of the tight junction between the bases of the retinal pigmented epithelial cell, this is to make the neurosensory retina isolated from the systemic circulation. This forms the outer blood retinal barrier. The tight junction here play a role in the formation of what is called the blood retinal barrier. So toxic material, large molecule, unwanted material can transmit from the choroid to the neurosensory retina. While the junction of the retinal pigmented epithelium, there is the adherence of the retinal pigmented epithelium with the photoreceptor, there is no such a tight junction, and there is a potentially space called the subretinal space between the retinal pigmented epithelium and the photoreceptor. In this subretinal space, there is a glycosaminoglycan adhesive substance. هي بتعمل هناك كلاصق كadhesion. Otherwise, there is no strong adhesion between the retinal pigmented epithelium and the photoreceptor. And in certain conditions, there is separation, pathological separation between the retinal pigmented epithelium and the neurosensory retina, and this condition called retinal detachment. Anyhow, let us return back to the function of the retinal pigmented epithelium. ذكرنا الفيرست one هو التاي junction والformation of blood retinal barrier ودورها إنه to get rid of toxic large molecule from passing from the choroid to the neurosensory retina. The other function here contain melanin, important in absorption of light. The other function here storage and releasing of vitamin A. الفيتامين A شنو أهميته بالفيجن اللي نريد نعرف الريليشن بين الفيتامين A أو perhaps الكاروت وهي الفيجن. خلي نعرف إنه الريتينال pigmented epithelium هي store and release the vitamin A. الفيتامين A هو مهم بالformation of photosensitive pigment. البيجمنت يسموها الرودوبسين والأيودوبسين، هاي صبغات موجودة بالفوتوريسبتر بالرود والكون، نسميها photosensitive pigment. الفيتامين A إلى دور بتصنيع هذه this photosensitive pigment، هو البريكيرسر لتصنيع هاي الفوتوسنسيتيف pigment. البيجمنت ضروري الامبورتنس اوف ذيس بيجمنت، هاي الفوتوسنسيتيف بيجمنت الريدوبسين والايودوبسين، هي absorb the light، والابزوربشن اوف ذا لايت ان انتي ريفلكشن ميكانيزم، يعني انه اللايت راح يعبر ما يرجع باك، راح يكون يمتد من الفوتوريسبتر الى البايبولر and forward. it work in anti-absorb in anti-reflection mechanism. زين، فهنا الفانكشن of the retinal pigmented epithelium هي storing and releasing of vitamin A اللي هو important for formation of photosensitive pigment. retinal pigmented epithelium important in metabolism of the in turnover of the outer segment of photoreceptor. احنا عندنا daily outer segment اللي هي adjacent to the microvilli. There is shaded of the outer segment of photoreceptor. منه مسؤول عن removal of this shaded part. It will removed by the retinal pigmented epithelium. فهذا هو الفانكشن of retinal pigmented epithelium. السبريتينال space هو avascular، يعني contain no blood vessel، يحتوي على glycosaminoglycan، ممكن يحتوي على amount of retinol but it doesn't contain large particles، ما يحتوي على blood vessels اللي هي may cause scattering of light، وهاي important in high information of the high resolution image. نيجي على النيوروريتنا. النيوروريتنا اللي هي نبدأ بالفوتوريسبتر، ومثل ما قلنا إنه there is outer segment embedded and surrounded embedded in the matrix of the subretinal space surrounded by the microvilli. there is no tight junction with the retinal pigmented epithelium. وهذه الفوتوريسبتر بيها أيضا الستاك and then the inner segment. بالنسبة إلى الفوتوريسبتر هي نوعين rod and cone. we have about 130 millions number of photoreceptor. 120 millions are rod and 10 millions are cone. الرود هي mainly at the periphery distributed at the periphery of the retina، وتكون responsible for يعني stimulation under low light level stimuli، يعني important in dark and in white black vision, important in detection of moving target, important in our visual field. الرود يعني مثل ما قلنا إنه هي numerous more in the periphery and it doesn't appear at the macula. Regarding the cone اللي هي 10 millions الكون responsible for the color vision, responsible for our sharp vision or visual acuity, important for static object detection. وهي more in the macula and the presence of the cone in the macula ممكن يكون يعني each one cone connected to one bipolar at the macula. Regarding this photoreceptor next to the photoreceptor احنا يعني من نحكي عن النيورونز in the retina نتحدث عن 3 types of the neuron اللي هي الفوتوريسبتور البايبولر الجنجليون cell. other cells هي supporting cell. من نتحدث عن النيورال cell يعني نقصد بيها الفوتوريسبتور البايبولر الجنجليون cell. الother cells اللي تشوفوها بالدايجرام هي supporting cell. إذا نتحدث عن البايبولار سيل اللي هي يسموها الفيرست اوردر نيورون بالنسبة إلى البايبولار ترانسميت يعني إنه الفيجوال إمبulses راح تنتقل هذه الفيجوال إمبulses من الفوتوريسبتور إلى البايبولار، فهذه نسميها الفيرست اوردر نيورون البايبولار سيل. الجنجليون سيل هي السكند اوردر نيورون اللي راح تنقل لي الامبulses الى الجنجليون سيل. هنا يكون transmitted الامبulses to the nerve الى الاكسون of ganglion cell in the nerve fiber layer. هنا عندنا important information إنه النيرف هي unmyelinated in the retina. Unmyelinated important here to prevent the scattering of light. The blood supply of the retinal layers, the outer 1/3 of the neural retina receive nutrient by diffusion from the choroidal circulation, while the remaining part supplied by the central retinal artery. blood retinal barrier هل important subject إنه هو why the retina isolated from the systemic circulation إنه هو no large particle permits to pass to the retina, large toxic molecule toxic drug can't pass to the retina بفعل blood retinal barrier. blood retinal barrier be outer blood retinal barrier and the inner blood retinal barrier. As you remember, the adherence between the bases of the retinal pigmented epithelium, the tight junction of the retinal pigmented epithelial cell هو represent the outer blood retinal barrier. The inner blood retinal barrier هو الكابيلاري of the retina اللي هي non-fenestrated capillaries. non-fenestrated endothelium of the retinal capillary هو form the inner blood retinal barrier. Both work together to isolate the retina from the systemic circulation, from the toxic material, from the large molecule as well. And now the applied anatomy. بعد أن درسنا الهيستولوجي الفسيولوجي خلينا نعرف ال clinical importance. This fundus photography. Fundus photography showing to us the macula, fovea, fovula, ample, optic disc and retinal vessel, artery and vein. خلينا ناخذ كل H1 alone. نبدأ بالماكولا. الماكولا هذه أول the outer circle اللي هي about 5 mm in diameter 5.5 mm in diameter. الماكولا أو ما تسمى بالماكولا اليوتيا لأنه تحتوي على xanthophyll pigment و more than one layer من الجنجليون cell in the macula. بالنسبة للماكولا الانر or the middle white circle هي نسميها الفوفيا. الفوفيا احنا اللي نشوفها اللايت ريفلكس at the border of the fovea due to increased thickness of the retinal layer at the border لأنه center of the fovea الفلور of the fovea اللي نسميه الفوفيولا هنا هو contain اللي هو thinnest part of the retina يحتوي على الفوتوريسبتور يعني retinal pigmented epithelium و photoreceptor only at the floor of the fovea. بالبريفري يصير عندنا increase بالretinal layer thickness وراح يبين اللايت ريفلكس at the border of the fovea. هسه الفلور اللي هو thinnest part واللي نسميه الفوفيولا there is only photoreceptor و retinal pigmented epithelium. طبعا الفوفيا measure about 1.5 mm in diameter يعني تقريبا نفس قد الأوبتيك ديسك in diameter the same بالنسبة إلى الفوبيا، وهي temporal to the optic disc slightly lower and temporal to the optic disc. Why this arrangement؟ يعني ليش عندي بس photoreceptor بالcenter of the فوبيا اللي هي منطقة what is called the fovula. هذا طبعا هالarrangement permit the incoming light to have a great access to the photoreceptor than elsewhere in the retina. يعني great accessibility explain in part why this central depressed area has the most distinct vision. ليش هي تكون مسؤولة عن sharp vision، عن highest visual acuity، بسبب in part هو this arrangement، لأنه there is only photoreceptor and no ganglion cell layer in this in this part, in this depression. طبعا other feature إنه there is no rod, only cone photoreceptor. والcone photoreceptor in the fovula تكون tightly packed، يعني خلينا نقول higher density of the cone, a higher concentration of the cone هو in this area, and why there is a closely packing of the photoreceptor, a highly packed photoreceptor in this area هي اللي تكون مسؤولة عن sharpest visual acuity in this area. وبعد إنه there is no blood vessel، فصار عندي 3 features تميز الفوبيولا عن other part of the retina. تميز إن الفلور of the fovea عن other part of the retina إنه هو only photoreceptor layer، إنه هو no blood vessel و only cone and also tightly packing of the cone in this area. فصارت الفوبيا هي المسؤولة عن sharpest visual acuity. يعني لو patient have a problem anywhere in the retina، حتى ولو كان انفصال الشبكية بس بعيد عن الفوبيا، ممكن يجيك الفيجوال acuity مالته 6/6. لكن أي lesion in the phobia affect first the visual acuity. ليش؟ لهذه الأسباب اللي حكيناها، إنه this area responsible for your sharpest visual acuity. بداخل الفوبيولا عندنا الأمبو اللي هي dot like highly shown by the yellow circle. الفندس فوتو توضح لنا غير الماكيولا وال parts within the macula الأوبتيك ديسك. هسا الأوبتيك ديسك اللي هو nasal to the macula, about 3 mm nasal to the macula. The diameter of the optic disc هو 1.5 mm in diameter. هذا مثل ما نشوفه احنا بالفندس فوتوغرافي اللي هو pale pink color of the optic disc. البيل هو central wide depression بالoptic disc. remaining part ده شوفوا البينك color. السنترال وايد ديبريشن اللي هو الأوبتيك كاب سميناه. هنا راح نشوف emerging of the blood vessel اللي هي to enter the eye, central retinal artery and vein enter the eye through the central depression of the optic nerve. And slightly to the nasal side. شوفون الفزل هي emerge from the optic disc from the center and slightly to the nasal side. شو راح يبين عندي central retinal artery and vein. عندي superior بالبداية و inferior branch and then each branch راح ينقسم إلى nasal و temporal. In this fundus photo, I want to show you the layers of the retina, how it appear by this image called optical coherent tomography, the retinal OCT. In the central the central depression, the floor of the fovea is the fovula. This area there is only retinal pigmented epithelium and photoreceptor. There is no ganglion cell layer in the fovula, and for that you see the central depression here and the reduced thickness of the retina. At the border of the fovea there is increased thickness of the retina, For that, the reflex appear by fundoscopy. The light reflex by the fundoscopy that we see at the border of the fovea when there is increased thickness of the retinal layer. This fundus photo also showing the foveal avascular zone, phase foveal avascular zone. Inside the fovea there is area without vessel, called the avascular area, foveal avascular zone, about 300 to 500 micron in diameter. And sometimes we show our student the retinal fluorescein angio, and I ask them about this avascular area, why there is this central avascular area, or what we call this central avascular area. This is a foveal avascular zone that appear dark on the fluorescein angiography. After we talk about retinal anatomy and physiology, let us start with certain retinal diseases like retinal detachment. Retinal detachment أو انفصال الشبكية هو separation of the retinal pigmented epithelium عن النيوروسنسوري retina. ومثل ما افتهمنا إنه there is no tight junction بين retinal pigmented epithelium والنيوروسنسوري الريتنا هو مجرد microvilli surrounded the outer segment of the photoreceptor، وعندنا subretinal spaces اللي هو with matrix. لكن if separation occur, whatever the cause is, the condition is called retinal detachment. الretinal detachment هي of many types. ممكن تكون rigmatogenous retinal detachment وممكن تكون non rigmatogenous retinal detachment. الريجما يعني هي الشق زين، فإما تكون الريتينال ديتاتشمنت نتيجة شق بالشبكية أو تكون non rigmatogenous اللي هي ممكن تكون Tractional أو exudative retinal detachment. Now the symptom of rigmatogenous retinal detachment. يعني احنا خليه نبدأ بالفوتو حتى نفهم السيمتوم. To start with rigmatogenous formation of retinal break. Okay, there is rigma, a break, retinal full thickness break in the neurosensory retina. فصار عندنا بريك بالنيوروسنسوري ريتنا whatever the cause. هذا البريك نتيجة أتروفي بالنيوروسنسوري ريتنا، نتيجة تروما للنيوروسنسوري ريتنا، صار عندي هذا الفول ثيكنس بريك. لحد الآن ما عندنا انفصال بالشبكية، عندنا فقط ثقب بالشبكية. هذول الناس المعرضين للثقب بدون تروما نون تروماتيك بريك اللي عندهم ريتينال ويكنس أو أتروفي بالريتنا، مثلا خلينا نقول الهاي مايوبيا، الباثولوجيكال مايوبيا، الناس اللي عندهم قصر بصر عالي واللي تكون الريتنا ثين ريتنا تكون معرضة لتكوين الريتينال بريك. زين، هنا before retinal detachment مجرد ال formation of the retinal break ايش راح يكون؟ طبعا احنا هنا if there is liquefied vitreous gel، يعني إذا هذا ال vitreous humor اللي هو gel like vitreous، if there is liquefaction بال vitreous humor اللي تحدث with age أو earlier in patient with high myopia liquefaction or with changes in the vitreous occur in early age group. If there is liquefaction بالvitreous humor، هذا liquefied vitreous gel can pass through this break، وهو هذا البريك هو full thickness break. the liquefied gel will stay in the subretinal space and it will separate the neurosensory retina عن الretinal pigmented epithelium، وصار عندنا retinal detachment. فالretinal detachment يتطلب الريجماتوجينوس retinal detachment يتطلب وجود الretinal break full thickness break whatever the cause، ويتطلب وجود liquefied vitreous gel، وبالتالي راح يكون formation of the retinal detachment. السيمتوم يعني هنا إذا هذا ال detachment occur in the macula راح يكون early drop of visual acuity، يفقد النظر، وإذا كان little bit away من الماكيولا ممكن راح يسوي لنا visual field loss، يعني ممكن البيشنت عنده good visual acuity and there is retinal detachment away from the macula. نقول retinal detachment with macula on، يعني still the macula attached. فالvisual acuity in this patient will be good and there is only visual field loss. Other symptom اللي هي الفوتوبسي والفلوتر related to the break itself، وممكن قبل مرحلة الديتاشمنت يكون المريض experience these symptom، يعني يكون experience flashes of light، يشوف flashing of light. ممكن يعني هذا المريض بالريتينال ديتاشمنت من أسأله قبل الديتاشمنت قبل أسبوع قبل أكثر، يقول كان عندي flashing of light، أشوف بالآي نفسها اللي هي develop retinal detachment. أوكي، وهل flashing of light سببها there is vitreoretinal traction. أوكي، يعني إحنا patient قبل مرحلة retinal detachment كان أكو ما يسمى posterior vitreous detachment، انفصال السائل الزجاجي. posterior vitreal detachment إنه هو detached but there is area of adhesion, still adhesion, and there is vitreoretinal traction in that area. فهذا التراكشن إذا استمر ممكن يسبب لي retinal break، والمريض راح يكون يشوف flashing of light، perceived flashing of light due to the vitreoretinal traction in that area of vitreoretinal adhesion. بالنسبة إلى الفلوترز هي moving vitreous opacity that perceived by the patient when they cast shadow on the retina. يعني شنو؟ يعني هذه moving vitreous opacity احنا قلنا المفروض قبل مرحلة الديتاشمنت كان أكو بريك، وقبل البريك كان أكو posterior vitreal detachment، انفصال السائل الزجاجي. أغلب مرضى انفصال السائل الزجاجي راح يقول أشوف أكو فد moving vitreous opacity، أشوف مثل الذبانات تتحرك، مثل النمل، مثل الديدان. قسم يقول أشوف مثل خيوط العنكبوت. هذه moving vitreous opacity بسبب chemical changes inside the vitreous، and this opacity بسبب posterior vitreous detachment أيضا ممكن تكون هي glial cell شدد من الأوبتيك ديسك، ممكن تكون blood cell موجودة، ممكن degenerated collagen داخل الفيترياس. المهم هذا اللي راح يشوفه المريض، هاي الأوبازيتيز وين cast shadow on the retina راح يحسها المريض، يشوف هذه الأوبازيتيز المتحركة. اوكي، واغلبنا احنا شايفين هيجي حالة moving vitreous opacity ونخاف منها، لكن احنا usually البيشنت in acute attack نفحص الفندس ونسأله ورا 3-4 أسابيع to come back again for examination، وهي يعني in about less than 10% ممكن associated with formation of retinal break. يعني هاي الحالة مال posterior vitreal detachment أو posterior vitreous detachment اللي نسميها PVD ممكن تكون pass without any complication اللي هي high mostly، وممكن it may cause complication اللي هي formation of retinal break، أو ممكن يسبب لي very rarely vitreous hemorrhage. وإحنا لهذا إنه we advise the patient to come back again for examination للposterior جماعة posterior vitreous detachment. هسه if associated with a break، إذا هي بس posterior vitreous detachment المريض يشوف الفلوترز، هاي moving vitreous opacities اللي نسميها الذبابة الطائرة، اللي يشوف مثل الذبابة أو مثل خيوط العنكبوت المتحركة وهي حركة العين، وممكن when close the eye أيضا يشوف هذه الأوبازيتيز. also the person can't perceive that، لكن إذا صارت complication وسببت لي retinal break بسبب vitreoretinal traction in area of vitreoretinal adhesion راح تسبب في thickness break والvitreous already liquefied pass through this break and cause retinal detachment. وهذا المريض اللي كان عنده history of floater and photopsia راح يجيني drop of vision إذا البريك involve the macula، أو يجيني visual field loss إذا كان يعني still the macula attached and ممكن يكون upper field loss أو lower visual field loss. هذه هي symptom of rhegmatogenous retinal detachment. This two fundus photo اللي هي right و left showing the retinal degenerations اللي هي ممكن predisposed to the formation of retinal break and holes. يعني ليش تتكون break and holes؟ إذا ما كان المريض متعرض لتروما نسميها non-traumatic retinal breaks and holes اللي هي تكون secondary to retinal peripheral retinal degenerations and weakness، اللي هذه مثلا عندنا بالرايت area نسميها lattice degeneration، بالleft area there is different area of retinal degenerations developing the retinal holes. Regarding the treatment of the retinal break, not the rhegmatogenous retinal detachment، يعني retinal break قبل مرحلة formation of fluid in subretinal space، قبل separation of sensory retina عن retinal pigmented epithelium. When I detect the break اللي هو symptomatic break، يعني patient هنا عنده photopsia والfloaters هنا we surround the break by 2 rows of laser، هذه نسميها laser photocoagulation prophylactic laser photocoagulation surrounding here in the picture hole just hole whether macular hole or tear we surrounded by laser to create adhesion حتى شنو to prevent development of rhegmatogenous retinal detachment. The treatment of retinal break by laser, prophylactic laser photocoagulation. But once there is subretinal fluid and development of retinal separation, the laser will be ineffective and the treatment will be by retinal surgery. The surgery we call parsiplana vitrectomy for retinal rhegmatogenous retinal detachment. The first type من الretinal detachment كان نتيجة formation of full thickness break اللي هو الريجما، فصار اسمه rhegmatogenous detachment. Other type اللي هي non-rhegmatogenous detachment منها Tractional detachment، يعني إنه there is no break بس أكو traction on the neurosensory retina that separated from the retinal pigmented epithelium، وهذا traction يتكون نتيجة formation of fibrovascular membrane يشد neurosensory retina ويسحبها عن retinal pigmented epithelium. هذا fibrovascular membrane يتكون نتيجة different pathological condition مثلا proliferative diabetic retinopathy أو نوع من الريتينوباثي نسميه retinopathy of prematurity اللي يحدث بالخدج. النوع الآخر هو نتيجة السيكل سيل ريتينوباثي، أيضا هي type of proliferative retinopathy، وممكن تتكون هذا الفايبروفاسكولار membrane secondary to ocular trauma. فthese type all المشترك بيناتهم هو formation of fibrovascular membrane that pull the neurosensory retina from the retinal pigmented epithelium lead to formation of tractional retinal detachment. Tractional retinal detachment as a symptom، يعني هنا أنا ما عندي break ف there is no photopsia and floater. وجود الphotopsia and floater يكون with the presence of the retinal break. فهنا ما عندنا retinal break ف there is no photopsia and floater، لكن راح يكون عندنا loss of the visual acuity. Central loss of visual acuity طبعا إذا كان التراكشن involve the macula sure، أو ممكن يكون عندنا visual field loss إذا كان peripheral ممكن. loss of visual acuity little bit gradual not acute like in patient with rhegmatogenous retinal detachment. هنا التراكشن occur slowly till there is full separation، فيكون gradual loss of visual acuity and not sudden loss of visual acuity in patients with tractional retinal detachment. الثيرد تايب من الريتينال ديتاتشمنت واللي هو السكند تايب من النون ريجماتوجينس هو الاكزوداتيف ريتينال ديتاتشمنت. اكزوداتيف ريتينال ديتاتشمنت او اللي يسموها الميديكال ريتينال ديتاتشمنت لانه ما تحتاج اي سيرجيكال انترفينشن عكس الاذر تايب. هنا تكون هي secondary to leak from the retinal blood vessel or secondary to RPE damage it can occur. فالfluid pass into the subretinal space. فthe source of the fluid in subretinal space هو secondary to the retinal leak from the retinal blood vessel أو to the RPE retinal pigmented epithelial damage. من ال causes of this exudative retinal detachment هو ممكن يكون secondary to toxemia of pregnancy malignant hypertension، يكون نتيجة اليوريميا، ممكن secondary to posterior scleritis، secondary to retinal أو choroidal tumor. ممكن نشوف هذا ال exudative retinal detachment يكون bilateral at the same time. طبعا السيمتوم مالته مع no photopsia or floater، وعندنا ممكن يكون field loss اللي هو develop suddenly and progress rapidly. الميزة اللي تميز هاي الاكزوداتيف ريتينال ديتاشمنت نسميها الفلويد شيفت. يعني مثلا انت البيشنت in sleep in supine position تشوف الديتاشمنت superior، ممكن تقعد البيشنت ونفحص نلقى الديتاشمنت راح يكون inferior اللي هو يعني subretinal fluid here respond to the force of the gravity. هل الشيفت of the fluid هي characteristic for exudative retinal detachment؟ والother feature إنه هي ما تحتاج surgical intervention، ممكن تكون bilateral presentation together. التريتمنت of exudative retinal detachment هي التريتمنت of the pathology itself. يعني مثلا إذا عالجنا posterior scleritis ولا we reduce the blood pressure in the patient with malignant hypertension or we correct the uremia, exudative retinal detachment will disappear. هسه راح نتحدث عن important topic اللي هو diabetic retinopathy. Involvement of the retina in patient with diabetes. The risk factors اللي هي أهم risk factor هو the duration of diabetes and the control of diabetes. وممكن عوامل أخرى تساعد اللي هي like the presence of other diseases اللي هو hypertension, nephropathy مثلا hyperlipidemia, obesity, anemia, smoking. يعني هاي كلها ما enhance the development of diabetic retinopathy. هسا شنو ال diabetic retinopathy؟ هو involvement of a small blood vessel اللي هو microangiopathy in which the small blood vessel more likely to be involved. The pathogenesis هو microvascular occlusion or microvascular leakage، وممكن يكون direct يعني toxicity to the retinal cell as well. فكل ما نشوفه بالدايابيتس بالdiabetic retinopathy هو ممكن يكون sequences of microvascular occlusion and or leakage or maybe due to direct toxic effect on the retinal cell, which may also play an important role as well.
All the story with diabetic retinopathy is a consequence of the microvascular occlusion and or leakage. Microvascular occlusion caused by basement membrane thickening, endothelial cell damage, RPC change, platelet increase, thickness and aggregation, while microvascular leakage related to breakdown of a blood retinal barrier, loss of the pericyte, and formation of microaneurysm that will leak blood, will leak lipoprotein. What is the sequences of microvascular occlusion? Microvascular occlusion lead to retinal ischemia and retinal hypoxia. This hypoxia will stimulate the growth factor, the vascular endothelial growth factor formation. This overstimulation of vascular endothelial growth factor will lead to new vessel formation and this new vessel fragile that may rupture and cause bleeding. The site for this new vessel formation could be at the optic disc, could be elsewhere in the retina, or involve the iris. When it involves the iris, we call the condition rupiosis iridis. So the sequences of occlusion will be proliferative diabetic retinopathy with its complication.
The sequences of leaking from the microaneurysm lead to formation of retinal edema. The retinal edema may be localized, may be diffuse, extensive retinal edema. It depends on the type of leakage, whether it is localized or extensive capillary leakage.
The worldwide accepted and well-known grading for diabetic retinopathy include 4 grades. First of all, background diabetic retinopathy. Number 2, pre-proliferative diabetic retinopathy. Number 3, proliferative diabetic retinopathy. Number 4, advanced diabetic eye disease. And maculopathy can occur in any one of them.
Let me explain to you this fundus photo. According to the grades of diabetic retinopathy we have already taken, and according to the pathology that we discuss, in what appear in this fundus photo is the consequence of the leakage, not the occlusion. Here in this fundus photo, let us describe there is a hard exudate. This yellow waxy deposit, yellow waxy lesion اللي هي with sharp border appear represent a chronic retinal edema, a chronic leakage, and this is called hard exudation. And what we find else, there is 2 types of hemorrhage. There is round hemorrhage, dotted plot hemorrhage, and there is a flame-shaped hemorrhage. These 2 types of hemorrhage reflect the layer where the hemorrhage occur. If it is occur in the retinal nerve fiber layer, it takes the shape and the architecture of the retinal nerve fiber, so it appear like a flame-shaped hemorrhage. The intraretinal hemorrhage appear like the dot plot hemorrhage. So we have the 2 types of hemorrhage here. Microaneurysm also appear as a red dot. يعني هذا الساكولار outpouching of the capillary اللي هو المايكروانيوريزم اللي هو source of the hard exudation اللي هو source of the leakage appear as a red dot for better differentiation إنه هذا microaneurysm له red dot hemorrhage. We can do fluorescein angio. يعني بالفلوريسين angio راح يتوضح المايكروانيوريزم اللي هو leaking and hyperfluorescence, while the hemorrhage give a hypofluorescence appearance on fluorescein angiography. So this photo is a background diabetic retinopathy. There is hard exudation and there is hemorrhage, the 2 types of hemorrhage. This is a background diabetic retinopathy. Again, in this fundus photography that's showing there is hemorrhage, intraretinal hemorrhage, and some flame-shaped hemorrhage, and there is retinal, there is hard exudation. This yellow waxy deposit that represent protein, lipoprotein and lipid-laden macrophage اللي هي اتكون secondary to the leaking microaneurysm. some هو طبعا localized as a cercinate نسميه circular localized هذا exudation نسميه cercinate lesion, و other hard exudate deposit here and there within the macula. This is a background diabetic retinopathy, but here the exudation involves the macula and very close to the fovea. As you see, I will explain to you the treatment later on in the following slide. In this slide, in this fundus photo with the fluorescein angiography, we inject fluorescein, intravenous fluorescein, and then we capture the fundus photo, and we see the flow of the fluorescein in the retinal vein, artery, and within the retinal capillary. We see in this fundus there is a hyperfluorescent lesion, small hyperfluorescent lesion اللي هي represent microaneurysms, and there is central dark area اللي يشوفوها هذه circular central اللي هي represent the foveal avascular zone that I told you about within the fovea. هذه central dark اللي هي foveal avascular zone، وعندنا surrounding in the macula there is multiple microaneurysms, hyperfluorescent lesion.
This fundus photo shows a pre-proliferative diabetic retinopathy. Why a pre-proliferative? There is cotton wool spot. This is the cotton wool spot, previously called soft exudate. Now we call it cotton wool spot with vascular change. The vascular, mainly venous change, venous dilatation, and this vein segmentation, sausage-like vein, and intraretinal microvascular abnormality in the form of shunt between the arteriole and venule. In this condition, the pre-proliferative diabetic retinopathy, if not associated with macular edema, the treatment will be follow-up only. But in a condition when the patient, only eye patient, the fellow eye has been lost from complications of diabetes, so we can give pararetinal photocoagulation just for this indication. Patient can't attend regular follow-up, and the only eye in patient with when fellow eye has been lost from the complication of diabetic retinopathy. This slide shows the sequence of microvascular occlusion, retinal ischemia, and then formation of a new vessel. So this is a proliferative diabetic retinopathy, and the patient can develop vitreous hemorrhage due to rupture of this fragile new vessel. This slide also a sequence of microvascular occlusion, formation of a new vessel, but this new vessel are the disc. We called this is NVD. New vessel are the optic disc. The new vessels are fragile. The patient may develop vitreous hemorrhage, so he's in a stage of a proliferative diabetic retinopathy.
Another photos showing the proliferative diabetic retinopathy. The left one with extensive NVD, new vessel are the disc, and the right photo showing the vitreous hemorrhage.
Our patient with a proliferative diabetic retinopathy and with a new vessel are the disc, a new vessel elsewhere, who doesn't receive treatment, he may present to us with sudden painless drop of vision due to development of vitreous hemorrhage. When we want to examine the fundus in patient with total vitreous hemorrhage, there is no fundus view like this slide. So this is a sequence of proliferative diabetic retinopathy with no effective treatment. This slide shows the treatment of proliferative diabetic retinopathy for new vessel at the disc, a new vessel at elsewhere in the retina, or even a new vessel at the iris. For this patient with a proliferative diabetic retinopathy and good media, not hazy media, not complicated by vitreous hemorrhage, the treatment will be a laser pararetinal photocoagulation. This is a destructive procedure aimed to reduce the oxygen demand, destroy the peripheral retina, to reduce the oxygen demand, to keep the oxygen mainly for the macula, the area that is responsible for your visual acuity, to keep the oxygen for the macula only, to reduce the stimulation of vascular endothelial growth factor. And if you examine the patient after the laser session, condition, if your treatment is successful, you should see there is regression of the new vessel. Here we have two fundus photo. The left one with the yellow fresh laser spots, while the right one with the black laser spots. These are old laser scars. This modality of treatment used for proliferative diabetic retinopathy. Advanced diabetic eye disease are the complication of proliferative diabetic retinopathy in patient who doesn't receive treatment at all or is insufficiently treated. So the patient may present to you with sudden painless loss of vision, and your differential diagnosis at the head of the list should be vitreous hemorrhage. So, in case when we suspect vitreous hemorrhage and we don't have a clear fundus view, our tool should be ultrasound, ocular ultrasound. The rule of ocular ultrasound is to differentiate whether your patient with vitreous hemorrhage alone or vitreous hemorrhage with tractional retinal detachment, because the treatment will be different. So in our patient in the upper left photo, there is both vitreous hemorrhage and tractional retinal detachment. The treatment here will be vitrectomy and retinal reattachment surgery. But if the patient with vitreous hemorrhage and P-scan shows only vitreous hemorrhage without tractional retinal detachment, so the best treatment, the hemorrhage can resolve alone just by follow-up, or we can give intravitreal injection, anti-VEGF, antivascular endothelial growth factor. This is given in sequences, a monthly injection. Each 1 month we give 1 injection until the hemorrhage resolves, and then we give the definitive treatment, that is pararetinal photocoagulation. While in left upper photo, when there is hemorrhage, this is a pre-retinal hemorrhage. There is hemorrhage, but there is fundus view, so we can give the laser spot, we can give pararetinal photocoagulation, and also antivascular endothelial growth factor injection, because the treatment, for the combination of the treatment is better than when we use each one alone. Advanced diabetic eye disease. The stage of the complication, the blinding complication of proliferative diabetic retinopathy in patient who doesn't receive treatment at all or is insufficiently treated. So the complications are vitreous hemorrhage and retinal detachment. The patient with diabetes, when he presented to us with sudden painless loss of vision, we should exclude vitreous hemorrhage. And our workup here, when there is, especially when there is total vitreous hemorrhage and there is no fundus view, the best tool here, or first tool to be used, ultrasound, ocular ultrasound. You should order for ocular ultrasound, and this is to differentiate whether the patient has retinal hemorrhage alone or a vitreous hemorrhage alone, or there is vitreous hemorrhage with retinal detachment, because the treatment will be different here. If there is only vitreous hemorrhage, the treatment will be antivascular endothelial growth factor, and this is anti-VEGF, intravitreal injection of antivascular endothelial growth factor, that's given monthly, 1 injection per month until the hemorrhage resolves, and so we can give the definitive treatment, that is pararetinal photocoagulation, because while there is hemorrhage, there is underlying proliferative diabetic retinopathy, and the definitive treatment for proliferative diabetic retinopathy is the pan-retinal photo. Whenever we have a fundus view in a patient with vitreous hemorrhage and we can give laser treatment, the best option to give the laser treatment. Anti-VEGF given when there is no fundus view, and the combination of both anti-VEGF with pan-retinal photocoagulation give the best result, better than if we use each one alone. Other photo showing the this patient we have vitreous hemorrhage plus tractional retinal detachment. There is retinal detachment as well, so the treatment will be vitrectomy and endolaser, reattachment surgery. So there is so for this patient we can't give laser, we can't give pan-retinal photo, we can't give anti-VEGF. The best treatment for a patient with vitreous hemorrhage and tractional retinal detachment, vitrectomy and reattachment surgery. An important question I want to ask you about: does a patient with background diabetic retinopathy or pre-proliferative diabetic retinopathy or even proliferative diabetic retinopathy develop drop of vision? The typical answer is no. Why they don't develop drop of vision? Because there is no macular involvement, there is no complication. A patient with a proliferative diabetic retinopathy may present to us with 6/6 visual acuity unless there is complication like vitreous hemorrhage, but we treat him to prevent the development of vitreous hemorrhage. We want the new vessel to be regressed. So why patient with background diabetic retinopathy doesn't develop a drop of vision? Also, if there is no macular involvement, there is no loss of vision. In pre-proliferative diabetic retinopathy, the answer is the same. There is no macular involvement, the visual acuity is good, and our patient may have 6/6 visual acuity. But if the diabetic patient develops gradual paleness, loss of vision, we should examine the fundus and investigate for possibility of diabetic maculopathy. What is maculopathy? Maculopathy when there is involvement of the fovea by edema, exudation, or ischemia. How we differentiate whether there is edema, exudation, ischemia of the fovea? The definitive diagnosis by fluorescein angiography. Fluorescein angiography will show if there is macular ischemia, reduction of the macular perfusion, and if there is macular exudation, will show the leakage, the site of leakage and the source of this exudation by the fluorescein angio. And the macular edema, for macular edema we can do what is called macular OCT, optical coherence tomography, that will show the macular, the normal macular thickness and if there is macular thickening or not. In this photo, there is hard exudation, yellow deposit that involve the macula. If you say this is background diabetic retinopathy, so you will suggest just follow up, and this is not accepted in this patient when there is drop of vision and there is macular exudation and the exudation close to the fovea. The stage, the grade will be diabetic maculopathy, and the patient need to be investigated by macular OCT to know if there is macular edema, associated macular edema, and you can do fluorescein angiography, the definitive tool to know if there is macular ischemia or not. And the treatment here, not follow-up only. We should interfere if there is macular edema, exudation, and there is leakage by the fluorescein angio. The treatment will be focal laser photocoagulation. We give the laser not as a pan-retinal photo for the peripheral retina. We give the laser spot focal laser photocoagulation for the leaking microaneurysm, and the edema will be regressed. But if there is macular ischemia, laser focal photocoagulation is contraindicated here. Is there any other tool other than focal laser photocoagulation for macular edema or for macular exudation? Yes, we can. When your patient has macular exudation and you want to be sure there is associated macular edema or not, the definitive diagnosis by macular OCT. You should order for macular OCT, and this is a color-coded map to measure the macular thickness. It gives the green color for normal thickness, yellow for borderline, and the red color for increased macular thickness. In this case, there is overall thickening of the fovea, parafoveal area, and perifoveal area.
And this is a summary slide. I collect different photos from different grade of diabetic retinopathy. For example, starting with a fundus photo, there is mild background diabetic retinopathy, and here there are no treatment required, and the patient should be reviewed annually. We should control diabetes, other disease like hypertension, anemia, renal problem. All these factors should be addressed. Regarding the B photo, there is a pre-proliferative diabetic retinopathy, vascular changes, beaded veins, sausage-like erma, and cotton wool spot. In the pre-proliferative diabetic retinopathy, the patient should watch closely, and for the risk of development of proliferative diabetic retinopathy, no treatment required unless there is certain indications. The fellow eye has been lost from diabetes, from the complication of diabetic retinopathy. The patient can't attend regular follow-up, for example, so pararetinal photocoagulation also can be done. In all stages, the effort for diabetic control, reduction of any other systemic risk factor is very important. Regarding C fundus photo, there is proliferative diabetic retinopathy, aggressive NVD, new vessel at the disc, and here pan-retinal photocoagulation should be done regardless of visual acuity. Even when the patient has 6/6 visual acuity, I should do pan-retinal photocoagulation for this patient to prevent development of complication. Here, for example, in D photos, the first one showing the vitreous hemorrhage as a complication of a proliferative diabetic retinopathy for the patient who doesn't receive the treatment, or the treatment inefficient, ineffective. For example, he developed drop of vision, and the complication of proliferative diabetic retinopathy, that is the vitreous hemorrhage. Here the treatment in this photo, when I have fundus view, I should do pararetinal photocoagulation, which can be combined with antivascular endothelial growth factor intravitreal injection. The treatment when we combined both modality is better than to treat with each one alone. And for the D, when there is the last photo, when there is a tractional retinal detachment, as I showed with the white arrow, for the patient with the tractional retinal detachment, here I can't give intravitreal injection. The treatment here for tractional retinal detachment, the Parsiplana vitrectomy with endolaser. So in patient with diabetic retinopathy. The causes of a drop of vision ممكن يكون sudden loss of vision مثل الفيتريوس hemorrhage، وممكن يكون gradual loss of vision the patient develop, for example, in tractional retinal detachment. Other cause for gradual loss of vision in patient with diabetes may be the development of diabetic maculopathy, as other slide will show how we manage a patient with diabetic maculopathy. And this is the summary slide for diabetic maculopathy. To start with, we should differentiate whether this maculopathy is ischemic or exudative. Suppose it's confirmed to be exudative maculopathy by fluorescein angio, then we should do OCT, the optical coherence tomography, which can detect the response to treatment. So it is important for follow-up. The treatment modality, either focal laser photocoagulation, and this is under fluorescein guide. After our detection of the leaking point by the fluorescein angio, we can do focal laser photocoagulation to that certain leaking points, as the fundus photo showing the fresh laser spot. Other treatment for exudative maculopathy is intravitreal injection of anti-VEGF, which given a monthly injection. For example, the patient requires 3 to 6 injections. It's given at 1 month apart. Other treatment other than anti-VEGF is intravitreal triamcinolone. Intravitreal triamcinolone, as you know, is cataractogenous. It can cause cataract, and it has ability to elevate intraocular pressure. So we shouldn't give the triamcinolone for a patient with ocular hypertension or who has already glaucoma. We select this type of a treatment with intravitreal triamcinolone for pseudophakic patient with maculopathy that doesn't respond to other treatment modality, anti-VEGF or focal laser photocoagulation.